Next on our agenda, we have Dr. Pat Parfrey with Quality of Care Newfoundland and Labrador, or Choosing Wisely NL. Dr. Parfrey's talk is entitled 8 Major Interventions to Improve Health Outcomes and Reduce Health Costs.
So we have a problem. What's the size of it? Do we need to act urgently on it or not? And what are the potential solutions? So I'm going to go from one slide to 45. And it's pretty data heavy, and with my opinions inserted about what we should try and do. So here's our provincial spending as it is at the moment, 8.1 billion per year, of which 1.1 billion is servicing debt, and it's a deficit of $777 million. We're spending, I now believe, to be 38% in healthcare. That's the elephant in the room. That's the biggest piece of our health spending. And our net debt to GDP ratio is the highest in the country, and it's going to get bigger because we've got persisting deficits. It has already been mentioned about the age of the population. We've got the oldest population in Canada. 20% of the population is 65 years or older at the moment. 20 years' time, we're going to get even older. 34% of the population will be 65 years or older in 20 years' time. Why does that matter? Look at the effect on spending by age. After the age of 65, in Newfoundland, there is an exponential growth in health spending by age. Now, how about health spending here? It's already been mentioned. This is the size of the difference between the various provinces. We're spent $5,500 per capita on healthcare, which is the highest in the country. Are we getting value? So there's a health system scoring done by the Commonwealth Fund that looks at care processes, administrative efficiency, access, equity, healthcare outcomes. And you can see there's definitions for the care processes and the access and the healthcare outcomes. And these are integrated into providing a scoring system about how well our healthcare system is working. Now, this is the most important slide I'm going to provide. The top 3 countries, Australia, the United Kingdom, and the Netherlands, are in the top tier of health outcomes, health system scores. The United Kingdom spends less per capita on health than we do. Or if you integrate private spending, perhaps it's about the same. That's where they stand in terms of their health system spending. Look where we are. Canada is in the bottom tier, and we're in the lowest number of the provinces in Canada for health outcomes. We're as bad as the United States, and they don't cover care for 20% of their population. We're covering 100% of our population. So the healthcare value, i.e. outcomes divided by costs, is poor in Newfoundland. I would probably use another word. As a member of the healthcare delivery sector, I think it's shameful. And I honestly believe that all the people involved in making decisions, delivering care, and the healthcare workers involved should assimilate that piece of information and vow to change it. If you just look at the healthcare outcomes themselves, not process or efficiency, etc., we're the bottom of the pack. If you look at life expectancy for men and for women, you can see that our life expectancy for men is very low, 76 years, the lowest in Canada. And for women, it's the lowest in Canada. So what's happening in the healthcare system in Canada, and particularly in Newfoundland? So what we have is we've got a healthcare system that's economically driven by utilization. The public have universal access and they pay nothing. So they can demand what they want. And they do demand a lot. And that system is going to get worse. Demand is the component of the system. And it's facilitated by how we pay doctors. They're the gatekeepers. We pay doctors fee per item of service. So they get a reward for providing more services. So demand continues to grow and to grow. And demand pulls the system apart bit by bit, so people are fighting with each other. On top of that, you've got the unions and the NLMA want to get the best they can for their members, so they're pulling the system apart. The politics of healthcare delivery in the various regions of the province are pulling each other apart because one guy wants this hospital, another guy wants that hospital, etc. And the culture that's around healthcare at the present moment is such that everything is demanding from the healthcare system, and there's not support of a resource that everybody believes to be admirable, a universal access system that provides care to the community. We all believe in that, but we're tearing it apart. And on top of that, the communications that exist in terms of the way we communicate with the public about healthcare, and even how the media communicate about healthcare, driven by anecdotes and more driving us apart. So that's the way I see our healthcare system at the moment. It's fragmented and it's on the edge of falling apart. So how can we put it together in a more solid manner? What's this? Okay. Right, so let's look at the way we spend money in Newfoundland in comparison to the other provinces. Or you can really just look at Canada and Newfoundland. This is hospitals, other institutions, physicians, professionals, etc. But the key piece of information is that we have by far the highest spending on institutions in comparison to the rest of in comparison to Canada. And in particular for acute care hospitals, we have very high spending. And the modern context is that hospital use is going to get lower and lower. In every jurisdiction in the OECD, we're going away from hospital-based care. And we're spending 61% of our healthcare budget on institutions. So what do we need to do to improve this problem, which I believe personally is critical? We've got to spend more on healthcare determinants and do not increase the size of the healthcare budget, the proportionate size of the healthcare budget. We've got to restructure healthcare, as Dr. Haggie said, but we've got to do it in a manner that's going to upset some people because it means going from acute care to community-based care. We need to have an integrated healthcare system which is based on the primary health care with e-technology to integrate. We've got to reduce unnecessary interventions, which is a big problem. About 20 to 30% of our budget is spent unnecessarily. And I would argue that there needs to be a quality of care accountability structure to monitor, evaluate, intervene, and change the way we use healthcare resources. We've got to have improved access, which is the biggest problem for the population, and the quality of care by getting the right intervention to the right patient at the right time. I strongly support Pharmacare. I'm going to discuss innovation in healthcare delivery. And I really believe there needs to be a culture change by the citizens of this province in the way we support healthcare. So let's just deal first of all with the social determinants of health. As was mentioned, 50% of our life is determined by social determinants of health, not by healthcare delivery. Healthcare delivery about 25%. There's a recent publication that looks at social spending over the last 30 years. You can see it's flat. In every province, it's flat. And look at the healthcare spending. It's gone up very quickly over the last 30 years. Look at Newfoundland's healthcare spending, top of the pack. It was not the top of the pack previously, and now it's the top of the pack. And within that period, after 2001, you can remember post-Romano, there was a 6% increase in healthcare spending for 6 years. That didn't go into improving the quality of care. It went into salaries. The people delivering care made more money. So here you've got, this paper said that if they had spent 1 more cent in social services for every dollar spent in health, life expectancy of Canada could have increased by 5%. Now 5% is 4 years, right? That's massive. So if you look at it here in Newfoundland, using that logic, if the healthcare spending was reduced by 26 million and social spending increased by 26 million, you would get improved health with life expectancy increased by 5%. So I believe there's too little spent on the social determinants of health, which are issues that relate to poverty and housing and education, etc. So we need to increase spending on social determinants of health in lieu of increased spending on healthcare. Now, the proportion of healthcare spending can stay the same and continue to go up as we get more money. Now, what about restructuring healthcare? This is always a massive political problem. Wherever Saskatchewan, Ireland, wherever there's an issue about, oh, we got to reduce acute care hospital, the public goes crackers, right? And I understand it. I understand that they do, but when you look at the spending that we've got, there's 61% of our healthcare spending is on institution healthcare. We have to change. Here you see the hospitals that are around the province. There are actually 5 hospitals in St. John's when you think of it, in St. Clair's, the Health Sciences, the Waterford, the Old General Hospital. And what's the 5th? I can't remember. Huh? The Janeway, yeah. Carboneer's 50 miles away. You've got Clarenville, then you've got Gander and Grand Falls together. You've got Stephenville and Cornerbrook together, right? So there's an issue with our acute care spending. So there is excessive spending in institutional care. I do believe we need to decrease the number of acute care hospitals over time. And we need to replace them, not take them away, we need to replace them with community-based care that integrates primary care, emergency care, and long-term care. So we're not taking resources out of those communities. We're probably replacing them with something that's better. And I do believe, in opposition to what the minister said, that if you want to execute that mandate, you need one provincial health authority. Now let's move on to integrated healthcare. So the transformative change in healthcare that's been discussed by the minister, and Lynn will probably discuss it, needs to be enhanced and done more quickly. It should be, in my mind, the principles should be that the patient gets an enrollment with every patient has enrolled with a primary care provider, that there are group practices and networks with interprofessional healthcare teams, that payment schemes have got to be blended and include capitation and diminish the impact of seeing fee per item of service. There should be financial incentives for improved quality of care. There should be rostering in the evening and at weekends to diminish the effect on emergency rooms. And there needs to be a governance situation to control the way we use our healthcare resources. Because really, I don't think that our healthcare system can continue to be, in effect, controlled by family doctors who are accountable to nobody. So the way you could visualize integrated healthcare in more isolated regions, and in St. John's, for that matter, is that the primary place to deliver care should be in the community, with primary care, emergency room care, long-term care in the community, with outreach by nurse practitioners to more isolated regions, with contacts with long-term care, and these community centres feeding into a good acute care hospital system. And integration can be enhanced by technology. We've got the best electronic infrastructure in the country. We have an EMR, an electronic medical record that doctors are using to communicate with hospitals and maintaining data on their patients. We've got an electronic health record that brings all the information together from multiple different places, like hospitalization, drugs, x-rays, biochemistry, etc. We're developing e-ordering and e-decision making. We've communications with remote monitoring for patients in remote places. So we actually have the capacity to integrate across systems, across acute care, across long-term care, and across primary care with this electronic system. So the problem we've currently got is we've got a fragmented care delivery system. We've got communication gaps across sectors. We've got underserviced regions. So the solution, in my mind, is to transform community care and make it more dominant and use e-technology to integrate sectors. Now, what about unnecessary care? I'm just going to give you a few rapid-fire examples of unnecessary care, but unnecessary care exists throughout the gamut of healthcare delivery. This is Newfoundland for antibiotic prescriptions. This is the same graph in 2015. We're 33% higher than the next nearest province. And that's a problem because antibiotic use is harmful, because you develop drugs that are resistant to antibiotics, and we should be using much less. I would go so far as to say Quebec is too high. And look where we are in comparison to Quebec. CT scans per 1,000 population. CT scans are dangerous because of radiation. So if you're determining whether you need a CT scan or not, you got to balance the harms of radiation against the benefits of the imaging. And because of that harm, there are 21 guidelines from Choosing Wisely Canada on appropriate use of CT scans. And look what's going on with us. We have 216 per 1,000 people CT scans done every year, in comparison to 150 for Canada. We're doing CT scans on over 100,000 people a year. Unnecessary, inappropriate medications to seniors. Look at Canada's at 50%. 50% of medications are inappropriate in Canada. 50%. We're up to 2/3. And I can go on, et cetera, et cetera. Antipsychotics in long-term care were the highest in Canada. Restraint use in long-term care, 14.2 versus 6.5 compared to Canada. I'm going to give you two quick examples of two little projects we've done just to show you the way that you can affect change and actually make it more financially efficient. So it was our practice in people who had low to moderate risk surgery and themselves were at low to moderate risk of any side effects, to do blood work, chest x-rays and ECGs in all these patients. So in 2017, we put into effect an indication that we're to stop doing this. And the effect of just that simple thing, stop doing this, was and this is in Eastern Health, this is in St. John's, just St. John's, 39% reduction in ECGs, 47% reduction in chest x-rays, 22% reduction in INRs, a saving of 100 grand. The blood work, if you reduce the blood work, back down another 100 grand. If you extrapolate it to the rest of the province, you're going to treble the savings. So that's over $500,000 just by one direction of follow the guideline for Choosing Wisely Canada. Here's another one. So you can measure kidney function with two tests, a blood urea and a serum creatinine. We suggest you only need one. Just do the serum creatinine, stop doing the blood urea. So in 6 months after the guideline was propagated and discussed with doctors, there was a 46% reduction. That amounted to $90,000 saving, because the number of tests is so voluminous. 205,000 tests done in Eastern Health in 1 year. Tests only cost $2. So there's a savings of 90 grand. The potential annual savings in Eastern Health, if you don't use it in stable patients, is 300 grand further. The extrapolated to the province is another 300 grand. So across the healthcare systems, there are little things that are costing large amounts of money when we are unnecessarily using them. I'll quickly go through this. This is in Eastern Health, medical and surgical units, simple test, measure the sodium in the blood. Everybody gets it measured when they come into hospital. But you can see there that there are, over this period, 31,000 tests done once. There are 28,000 tests done twice. There are 22,000 people of the 31 getting it done 3 times. So you might say, well, but if it's abnormal, wouldn't you repeat it? I would. So now let's look at this metric. So the test was normal, not once, not twice, not 3 times. It was done again in 12,000 people of the 30,000 people, despite it being normal 3 times. What are the likelihood of it being abnormal the 4th time? 95% of them are normal, as you'd have guessed. And if you see the distribution curve, you can see that they're only a tiny bit low of irrelevant clinical importance. So this is just one test, costs $2. It's coupled with 4 more tests that cost another $2. All of them can be reduced. So the problem we have is there's no restraint on patient demand, because that's the way the system is set up. There's no control of doctor decisions, whether it's in hospitals or in community practice. What's the solution? Well, I think to deal with the public, you've got to actually make an effort to get out there and teach the public about what's necessary and what's unnecessary, why we do things and why we don't. Because the medical system doesn't want to go public. We need to. And then there's the question of economic disincentives for unnecessary interventions. That's user fees, etc. I'm very leery about that. Can the gatekeepers be able to provide less unnecessary care? We're already embarked in an audit, feedback and CME program with family doctors and with nurses. I do think that there needs to be economic incentives to reduce necessary care, i.e. people get rewarded for reducing unnecessary care, instead of getting paid more for each visit they see a patient. And again, I think a quality of care council is necessary, whereby there is a formal mandate to measure how we use healthcare resources, how we intervene in changing behaviour, and how we monitor change. Now, quality of care is the other side of the unnecessary use. So you need to get the right treatment to the right patient at the right time. So I'm going to give you an example of stroke care. We have the worst stroke care in the country. It's a bad thing, right? Getting a stroke. So probably the worst thing that could happen to you is to get a stroke. So you'd think that you need to ensure that you can do the best you can. So this graph shows you that we have the highest rate of strokes at 19% in people who've given a warning that they're getting a stroke, i.e. the healthcare system should be aware that these people are about to get a stroke in the next number of days. Transient ischemic attacks, we call them. In Canada, it's 12%. And the reason, what needs to happen is somebody gets a warning of a stroke, needs to have their carotid arteries tested immediately if they've got symptoms of disease in the carotid artery territory, immediately, within 24 hours. And people who don't have any symptoms that relate to the carotid shouldn't be getting the test. And in our lab, 40% are indicated based on symptoms, 60% are not indicated based on symptoms. So we've got a system where most of the requests arrive too late after the symptom onset to have the test and get the vascular surgeon to act so that he can get rid of the carotid stenosis. And access to urgent testing is diminished by a wait list for tests that are not indicated. Now, our approach to this is if we had an e-ordering system whereby you had no paper and doctors provided the clinical information so that you can determine priority, that may be something that will solve the issue of urgency. Now, on the other side of it, if somebody comes into the emergency room with a stroke, and if it's a clot that's caused a stroke, they need a clot-busting drug called thrombolysis. Our rate of providing thrombolysis in St. John's is 10%. It probably should be around 25%. In Clarnville, it's 30% because they've put into effect a process to ensure that a stroke that's called there's a code stroke and it's an emergency. We need to do that in St. John's and across the province. So the problem we have is across various things, we've got failure to get the right intervention to the right patient at the right time. There are solutions, practice improvement teams, e-ordering, and again, I would say you need a quality of care council that evaluates care, provides a recommendation about how to improve it, and follows through to see whether it is improved, i.e. a kind of a medical auditor general. So here's the way I'd visualize a quality of care council. It would require a provincial mandate and a budget, not very big, a trusted third party to evaluate care, apply Choosing Wisely Canada guidelines that's based on incontrovertible data, facilitate the right patient to the right intervention at the right time, translate knowledge to the public and to doctors, and in particular communicate with the public about how their healthcare dollars are being used. Now, I'm not going to spend much in Pharmacare. We don't spend as much on drugs as Ontario or Alberta, etc. do, and we probably should do. We don't really access new drugs that are relatively expensive. So the provincial government or the federal government are moving to see whether they can advance Pharmacare for the country. I think that it would be beneficial. It would decrease costs for drugs by partnering in a national program, bulk buying, and it would probably increase access to drugs demonstrated to improve outcomes because more money would come into the drug system. Now, we need to innovate in our healthcare system in Canada. That's happening across the country. It's feasible to translate successful innovations to our healthcare system from areas across the country that have been successful. But I would ask you the following question. If a province has our province the potential to embark on interventions that can improve health outcomes at reduced cost, where we've got a small population, geographically isolated, close linkages between stakeholders, and a state-of-the-art information system? Why can't we lead the country in trying to improve the Medicare? So I see a 50-year-old healthcare system providing low value, costing 38% of the provincial budget at a time of economic stress. We're in crisis, and pending geographic change that's going to increase the size of the crisis. I think we should grasp the opportunity for innovation and become a leader in transforming Canadian healthcare. So how much time have I got left? 3 minutes? All right. So in terms of the culture, I've demonstrated the fact that everybody is pulling the system apart. We need to get back to sustaining our healthcare system, supporting our healthcare system, and a culture change needs to occur in that we need to focus on health outcomes. We need to focus on public education. Like the reflection of the public is the proportion of no-shows, right? I mean, it's disgraceful. We are unnecessarily using interventions. That's a culture change. Should we consider return of service for medical students? Union demands, can that be done in a manner that is beneficial to everybody? And I'll come back to that. Can we diminish health as a political football? And can we get media reporting to be a bit more strategic in the way that it approaches healthcare rather than critical and using anecdotes? I've got 3 more slides. Okay. So I'm going to mention one thing just because it's so meaningful, I suppose, in terms of culture change. In the Victorian ages, talking about sex was taboo. In our age, talking about death seems to be taboo. And we're all going to die. And what's happening is that as we get frailer and frailer and frailer, such that when we're severely frail and very severely frail, we're going to die. What happens then, and what I don't want to happen to me, is I don't want to be in a nursing home with dementia, get a fever, taken out of my bed, put into an ambulance, taken to an emergency room, left there for 12 hours, given intravenous antibiotics, given intravenous fluid, put into a bed with 4 people who are not going to die, and have a death that's technologically aided rather than a death where I could die with dignity. That's what I need, and that's a big, this issue about how we die has only occurred in the last 30 years, driven by technology. Do we have to die with technology? So again, that's a very important issue in terms of how you change the culture around dying. Just briefly, again, nursing workforce is going to come up during the daytime. We've got the highest number of nurses in the country. It's likely because we've got the most institutions in the country. So not a big issue, at least in my mind. We've got the highest cost of absenteeism / overtime for nurses. And that's because they have an entitlement in their contract for a certain amount of sick leave. The issue, of course, is that the efficiency with which we run dialysis units and cardiac cath units and operating rooms, etc., is impaired by the amount of sick time, people who call in sick time. It's a soluble problem if there's goodwill. So there's patient demand, there's doctors' practice and remuneration, there's union demands, political competition, media reporting predisposing to fragmentation. Can we change a culture to support our major provincial asset? Can that culture bring together the elements that I mentioned earlier so that it's stable and can change over time? So the last piece is an aspirational request. And I think this aspiration shouldn't just be thrown out because we're an aggressive, I would say relatively immature society when it comes to major decisions. We have a crisis in healthcare. We have the lowest value healthcare in the country. It's as bad as the United States. Could we, and we being healthcare delivery, politicians, unions, NLMA, the stakeholders involved in healthcare, could we come to a 10-year health accord where we agreed upon our focus would be improving health outcomes? We could agree on the amount of the budget to be spent in healthcare. We would increase budget for social programs. We would restructure to community care. We'd have an independent quality of care council, and we'd support Pharmacare, and we'd change the culture from demand to support of Medicare. That's what I'd like to see happen. I actually believe it's a feasible thing, but it would require people to say that we're citizens of the province, all of us, and it's our healthcare system. Thank you.
Thank you very much, Dr. Parfrey. Lots of things to think about and discuss. So we've got until 5 past for some questions from the audience. If you could put your hand up and we'll get a mic to you. Over here.
Hi, Anne Carney, School of Nursing. So, Dr. Parfrey, you've asked for quality of care accountability structure, including a quality of care council. Our Minister of Health has, said that family doctors are self-employed business people. Certainly anyone who's on a fee-for-structure service is for-profit in a publicly funded system. So how close are we, or do you see any movement in our province for an accountability, cost-effective, appropriateness council as you describe?
So I probably have a conflict of interest here at one level, because we actually have a quality of care program that's done in collaboration with the NLMA and the regional health authorities and other stakeholders, in which we do actually evaluate care. We discuss how we're going to try and change the way that care is delivered, etc. But my belief is that the size of the problem is such that we should have a bigger mandate, and we should have a budget that's not driven by research funding, which is what our budget is driven by. So I think that what we're trying to achieve currently is actually very good. Whether or not audit and feedback and CME will change the way we use healthcare resources is open to question. So what do you do about if antibiotic use doesn't decrease? What do you do? Right? And I think that the capacity to affect change requires a stronger mandate.
And we got a question here in the back.
Dr. Tomlin.
Dr. Tomlin.
I'm interested in the idea of a health accord, but if you could give us more details in terms of what you are thinking in terms of a health accord. I mean, is it a legal accord which could be contested within the court, which would make a huge change in terms of giving power to transformation or change, or are you talking about a different accord?
I'm thinking strategically, not tactically. The lesson I've learned it from is what happened in Ireland. It happened twice, actually. The first time it happened where the economic union, Ireland became part of the economic union, or the European Union, and that brought money into the country, and Ireland decided to borrow more money and add it to the pot, and then it brought together the unions and the political parties and the business people and said, we're now going to work out how we're going to spend this, and we agree that we will have the following things that we're going to do over the next 10 years, and we agree to these salary increases based on our GDP, and we'll stick at it for 10 years. It was highly successful. And if an argumentative group of people like the Irish can do it, I'm sure those people who inherited their genes could do it in Newfoundland. And then subsequently, we had a similar response when we had the Celtic Tiger went bankrupt. And again, the major stakeholders in the economy came together to try and solve that, and now Ireland is not bankrupt anymore. So I aspire to the feeling, and I have to say that I was influenced by Jerry Earle's interview, whereby there was this controversy about the deal they did with the government where there was no layoffs, but they took 0% increase in thing, and they said, Jesus, boy, we're citizens of the province as well. We're not going to do something that would bankrupt the country, the province. So I'm saying, using the same logic, when we're in a crisis like this, could we not have the same teamwork in trying to get a solution to healthcare?
Yeah, we've got a question right here in the middle.
And he didn't swear, by the way.
There's almost nothing you said that I disagree with, but your optimism is something that I do not find entirely convincing. As the minister said, culture eats strategy for breakfast, and I'm wondering how you can build in enough teeth to the various ideas you've had so people actually have to change their behavior, because the evidence is very clear that doctors do not change what they do unless you actually force them, and politicians don't either. So where would the teeth be, say, on that picture?
So Lynn is going to come and talk about primary care as well. So I think that the gatekeepers are the gatekeepers for healthcare spending are the family doctors, and there is strong movements towards reforming primary care. I believe those movements should be strengthened, and there should be a commitment to try and ensure that we have primary practice teams across the province. We're doing it bit by bit. I think it just needs to be faster. I totally agree that culture devours strategy. Absolutely agree with that. But why not aspire to changing the culture? So I'm aspiring to changing the culture because I think that we have a system that nearly everybody in our province admires Medicare. They admire the fact that they've got universal access to healthcare, right? And they don't have to pay for it. So that, if you said you were going to change that, they'd all disagree. So now why not say, well, we like Medicare so much, we've got to start supporting Medicare. And that's why I'm aspiring to changing the culture. We've got to work at changing culture. And then you've got to work at having an accord across people who are usually fighting with each other. But I honestly believe that we're in a budgetary crisis that's driven partly by health. And it's going to get worse. Therefore, that's why I think we have to change.
Okay, we got time for one more question. Yep. Okay. Sorry, I didn't see you.
Hi, Dr. Parfrey, Yvette Hines, and I'm with the Registered Nurses Union. I've been nursing for 28 years now. I've worked cardiac critical care for most of it. I've worked outpatients, and now I'm at cancer care. You talk about healthcare spending. We're given $4,000 chemo on Friday, and the patient's at calls on Monday. People are not talking about death. People do not want to die. You are absolutely right about that. And physicians do not want to push it. If the families, right, are pushing for, we want the best care, we want the next line of treatment, whatever. We're giving, I think it is the 4th line of chemo here in Newfoundland. They're not giving that in Ontario. So where does the buck stop with that? Like, who makes them decisions? They're, as far as I'm concerned, they're political decisions. And, you know, cost savings on the backs of my family member? Like, who's going to make that decision?
Yeah.
The other thing, we talk about, you know, a health accord and communication.
I'm getting old, so I can deal with one thing at a time.
Okay.
Or as my mother used to say, one thing at a time, sweet Jesus. So, I mean, this issue of, my wife died from breast cancer 3 years ago, and I know from that she would have tried anything, right? And eventually she passed away, right? So I understand that people want to hold on to life, but I also believe that there's death with dignity. And I believe that our culture around that has gone, the pendulum has swung too far in favor of technology and not far enough. So we need to restart the discussions. We need to have palliative care. We need to have medical students taught better about how to deal with death. We need to have more comprehensive geriatric assessment, et cetera, et cetera. It's a culture change, really. But if you don't deal with it, nothing will change. We'll get worse. Right, what's their second question?
The communication piece. So I know Dr. Haggie said, you know, our IT is not up to snuff in the province. So I'm in Eastern
Or IT?
technology,
Yeah,
right?
yeah.
So I'm in Eastern Health. I don't know how long we've been together now. I was there when we were just a health science, the General Hospital, and then we became the Healthcare Corp. We have still not amalgamated all of our IT, and it's only this year that everybody, I'm going to put that in quotations, is getting the same email. That's 15, like at least 2,000 that the Grayson that closed. So, I mean, there's a lot of money that has been put into infrastructure such as IT, because our biggest issue in healthcare right now is communication. Everybody works in silo. The cardiac program works in silo. The cancer program works in silo. The medicine, the surgery. And everybody is trying to protect their own turf. We have a big cultural change that I don't know if this model is actually going to get to the root of it.
So, I mean, in terms of the e-technology part, health is going to go down that route no matter what. It's going to go down there fast. So, I think that the people who are not prepared to use e-technology are going to be left behind. So there's a resistance to change always in bureaucratic organizations. I think that the investment that we have in our IT infrastructure within the regional health authorities is not strong as it should be. But again, it's driven by demand for other services that relate to patient demand that we end up fulfilling. And it would be much preferable, in my mind, to have a better IT infrastructure to integrate healthcare, linked with NELSHI, than it would be to be spending some of the money we are on unnecessary care.
Okay, and I think we'll wrap that up there and move on to our next speaker. Thank you again, Dr. Parfrey.